Good afternoon. Welcome all members of the press who are on the line, and thank you for taking the time to listen to this briefing on the new Influenza A H1N1 outbreak given by the Pan American Health Organization. Before I go into details, I would like to take a moment to introduce myself. My name is Jon Andrus. I'm a senior medical epidemiologist and technical advisor for immunization here at the Pan American Health Organization. My 24 years in global health has largely been dedicated to the accelerated control and eradication of vaccine-preventable diseases in developing countries around the world. I have been asked by the director of the Pan American Health Organization, Dr. Mirta Rosas, to convene a daily press conference starting today on the current situation. The main purpose of these briefings will be to keep you all updated on the best available information to the extent possible, particularly as it evolves in our region in the Americas. We also want to share with you any new scientific information that's coming to us that will ensure that we are providing the best control strategies for this outbreak. Finally, we want to re-emphasize what individuals can be doing to protect themselves. This time together will allow you and provide you an opportunity to address any questions that you may have. I believe we are all working together, you the press, and us here at the Pan American Health Organization and our governmental colleagues in the field, working together to provide the most current information and best information to our citizens, so that ultimately individuals can ensure and protect their families and their communities across the world. At PAHO, we are also particularly interested and give the highest priority to ensuring that the available resources are distributed equitably among countries, particularly among people who need them most. So to begin, let's start by providing you a quick update on the epidemic. And I think as we hold these briefings, I would like to quickly update you, but not focus so much on the numbers, but discuss possible trends, because this is really going to help us refine our strategies. At the moment, globally, the latest data show that 820 confirmed cases have been reported due to this new Influenza A H1N1 virus from 17 countries. Those countries include Austria, Canada, China, Hong Kong, a special administration, Costa Rica, Denmark, France, Germany, Israel, Mexico, Netherlands, New Zealand, Republic of Korea, Spain, Switzerland, the United Kingdom, and the USA. Globally, we know there have been 20 deaths reported, 19 in Mexico and 1 in the United States. The data I cited includes 3 new countries in our region, Costa Rica and Colombia, and we have preliminary information that El Salvador today may be reporting 2 confirmed cases. In our region, with the data available, as well as the knowledge available from around the world, most experts would agree that the current outbreak that we're experiencing is mild to moderate in terms of severity. Of the cases in the U.S., from information we had yesterday, we know, for example, 5 cases have been hospitalized. The vast majority of cases recover fully. However, that is not to say that things cannot change very rapidly and very dramatically. What we know about influenza and RNA virus in general is that they are predictable by their unpredictability. The rapid and fairly aggressive response by PAHO and WHO has been appropriate given this completely novel strain of virus that is circulating. We need to be vigilant, but we also need to remain calm and not create panic and loss of public confidence. I think at this time it behooves us to remind ourselves of the 1918 swine flu outbreak. It started in the spring, much like the outbreak we're experiencing now in North America. Over the summer months in North America, the transmission diminished because ecological conditions of winter are more favorable for viral transmission. In North America, with the onset of fall and winter seasons, much more favorable for virus transmission, allowed the virus to come roaring back with a vengeance, and you know the story, killing 40 to 50 million people globally. So again, we cannot drop our guard. We must remain vigilant. Before going further, however, I'd like to share with you a special perspective that we have here in the Americas. Some of us here in this room have spent their professional lives fighting killer diseases like yellow fever and cholera. Others have fought hard to eradicate polio, a well-known crippler of children. More recently, countries have been working on the measles and rubella elimination initiatives in the Americas, also killers and cripplers of children. When you work in disease eradication, every day is an emergency. Every day that passes means more children are being paralyzed. So it is unacceptable not to work in such conditions where you must prioritize and keep things of an urgent nature. So I think in the Americas, countries have been highly successful in achieving these elimination strategies, and they are taking the necessary steps to deal with this outbreak. You may recall in the 1990s how cholera swept the hemisphere, causing 1 million cases and more than 10,000 deaths. There was widespread public panic. I remember working in Colombia at that time on the polio eradication initiative. Historically, it was the largest cholera outbreak of the 20th century. And if we put it in all of the time, of all historical time, people refer to it as the 7th global cholera pandemic. The countries with the support of PAHO responded well, and using the machinery of polio, we stopped transmission with mass campaigns for improving education, water, and sanitation strategies. So I think it is safe to say there's lots of experience, and I think the countries are responding appropriately to this new Influenza A H1N1 outbreak, and will be especially effective when we have more tools at hand. So the message is countries will know what to do and will do it particularly when vaccine becomes available. So to that end, WHO, in collaboration with PAHO, has established an Influenza A H1N1 task force, which is meeting on a daily basis starting last Sunday, the 26th of April. I'm a member of this task force. The task force is also composed of experts from other parts of the world, WHO, Geneva. The task force strongly recommends that seasonal influenza vaccination should continue, particularly when we consider that the Southern Hemisphere countries are now entering their winter season, the ecological time and conditions when seasonal influenza is most readily transmissible. So they are at a period of risk where we should implement seasonal immunization strategies as rapidly as possible. We know in the U.S. that seasonal influenza kills 36,000 people a year. So it's imperative that we stay on track with this strategy. WHO has already sent the new influenza A H1N1 virus to WHO-affiliated labs and to some pharmaceutical companies to start producing candidate vaccine virus strains that will ultimately lead to a vaccine. Aside from the traditional cell culture technologies and approaches to vaccine production, other newer technologies are now available, like reverse genetics, to generate a new H1N1 vaccine. This technology uses what we know about the genetic makeup or sequence of nucleotides to produce the surface antigen on the wild virus. These surface antigens produced as a result of this process will be included in the vaccine to provide the proper immune response to those people being vaccinated. This and other novel strategies are exciting areas of work because they provide hope and optimism that if the severity of this outbreak was to get worse, vaccine will become available more rapidly. Initial data suggests that despite the composition of last season's seasonal influenza vaccine, which included the Brisbane H1N1 strain, that this seasonal vaccine offers no cross protection to the current H1N1 infections that we are experiencing. Additional investigations are ongoing at this point and will provide the definitive answers, but all the data show that we have in hand to date shows that there is no cross protection. Those additional studies include the testing of sera from patients who participated in clinical trials, as well as animal studies in ferrets. So in essence, the vaccine manufacturers are pursuing several different strategies and pathways that will lead to a vaccine being produced, but all have different time frames. Hence, there's a range of estimates that we believe when the vaccine will become available. And right now, as we speak, we believe the best estimate is within the next 4 to 6 months. So what does that mean? I think that tells us that in the meantime, all our efforts should be highly focused on mitigating disease spread. And these strategies include the hand washing, the personal hygiene, and the social distancing strategies I'm sure you are aware of. But we really can't overemphasize the basics and the importance of these interventions. PAHO and WHO are not imposing any travel restrictions at this time, but we are advising very assertively that if you are ill, don't travel. And if you return from travel ill, please see your medical provider. I think at this point I should say something about all the work that's gone into the pandemic preparedness plans over the last few years. Because our group here at PAHO, with the oversight of the Influenza Task Force over the last few years, under the guidance of the director, Dr. Rosas, has done a tremendous amount of work in helping countries prepare their preparedness plans. And I think we're beginning to see the dividends of that work. We're seeing a very rapid, well-coordinated response between national, regional, and global agencies. In addition to the new vaccine production technology that I mentioned, there are several advances in the development of surveillance tools, such as new rapid test kits for the diagnosis of influenza H1N1. And these, as we speak, are currently being distributed by the Centers for Disease Control and Prevention of the United States. WHO will guide manufacturers on the signal when needed and, if appropriate, to switch from seasonal vaccine production to new influenza A H1N1 vaccine production. This will depend on many factors, including the relative disease burden and the severity of the current influenza H1N1 outbreak. Equitable distribution of vaccine to developing countries is an absolute top priority for PAHO, as I mentioned previously. As it stands, several manufacturers have pre-production contracts with certain countries which could impose barriers to vaccine access for the poorest of the poor. We need to keep advocacy and dialogue going to prevent a humanitarian crisis in lieu of possible vaccine shortages, particularly if the current outbreak were to become more severe. Once influenza A H1N1 vaccine becomes available, by all accounts, most likely we will not have enough supply to vaccinate everybody on the planet. Globally, perhaps 1 to 2 billion doses will become available according to the best WHO estimates, falling far short of the population on the planet. Vaccination strategies will need to target those individuals at higher risk. The data coming out of Mexico determining risk factors for morbidity and mortality will be critical not only for Mexico, but for the rest of the world. So we are working hard with all our partners to fill gaps in information that will ensure we are providing the best outbreak response. An excellent example of this is what happened just last night. Last night, Canada notified WHO of some 220 pigs being sick on a farm in Alberta, Canada, infected with the same influenza A H1N1 virus circulating in Mexico and the USA. We've been told that the farm has approximately 2,200 pigs, resulting in about a 10% attack rate. The farmer had a travel history to Mexico and returned home on the 12th of April. 2 days later, he was working with his pigs and at that time exposed the pigs to the virus he was shedding. Experts say this is not surprising and that the appropriate steps have been taken by placing the farm under quarantine. There's no evidence of other neighboring farm involvement. So with the data and knowledge that we have available, we are saying that there is no risk to purchasing pork in stores and eating properly cooked pork meat. So no one is saying stop eating pork. The food industry, with the support of the public health sector, should be on the lookout for illness among pig farms. Pig farmers who are involved with slaughtering live pigs, of course, may be at increased risk because of exposure to secretions from the pigs they are slaughtering. But the virus can only serve survive a short period of time. And by the time the pork meat has been processed and by the time it reaches the store, viral transmission is a non-issue. So this is just an example of how we must maintain our vigilance and be ready to react appropriately to the situation as it rapidly evolves. PAHO is working very hard to ensure there's equitable distribution of antiviral medications as well for the treatment of acute infections. Oseltamivir, which has been stockpiled by PAHO in Panama, in its Panama's office, and WHO also has global stockpiles. In both cases, medicine is being distributed to those who need it most. In fact, WHO rolled out yesterday its logistics plan for the distribution of 2.4 million treatment packs to 72 countries in need, including Mexico. PAHO is taking similar steps with its stockpile. And I think I'll stop there and entertain any questions that you may have.